Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight, my guest is Rachel Gage.
Hello.
Welcome, Rachel.
Thank you. Thanks for having me.
Yeah, it's great to have you. Rachel's a physical therapist. Rachel grew up in Boone,
Yep.
went to Iowa State, go Cyclones.
Yes.
Majored in kinesiology.
Correct.
And then got her Doctor of Physical Therapy degree at Des Moines University.
Yep.
And is a physical therapist, but also has some very specialized training after her physical therapy degree. And she has a training and certification in pelvic floor therapy, also pelvic oncology, breast oncology, and dry needling.
Correct.
So lifelong learning.
Yes, always,
Yeah.
always.
So we're going to talk a bit about the role of physical therapy in what I would like to say is cancer rehabilitation. How do we use physical therapy to help patients who may have symptoms from their cancer, or maybe even more commonly, symptoms from their cancer treatment, and the role of physical therapy?
Yep. Absolutely.
So before we dig into that, though, tell me a little bit more about yourself. When did you decide that you wanted to go into a medical profession?
Yeah.
And then specifically, how did you decide to go into physical therapy?
Sure. So growing up, my father was an optometrist, and I always had an interest in the medical field. I think just being around him and seeing what he did. Now, that's very different from physical therapy, but it piqued my interest in kind of the health world. So when I went to Iowa State, I started out in actually biology was my first major, and started taking that coursework. And then over time, kind of shifted my thought into more exercise science. My mom has been through physical therapy in her life, and she was the first one who brought it up to me. And I was kind of like, well, I don't know if I'm interested in that. But I had the opportunity to shadow physical therapists and kind of see what they do on a day-to-day basis. And it was just a really interesting area of medicine where you kind of use the body to heal itself. And it was just really fascinating to me. So I sort of ventured down that pathway with kinesiology, which is exercise science. And that led me to, physical therapy, and ended up in Des Moines University. And went my training through there. And then after I graduated from Des Moines, started in more of the outpatient orthopedic world of physical therapy, kind of traditionally what you think of physical therapy.
Right. I think that's what most people think about. You have knee replacement or hip replacement, or you've got some shoulder issues and you see the physical therapist. So how did you then branch out into these other forms of physical therapy that are really more that we use more for cancer rehabilitation?
Yes. Yeah. So you learn about some of the specialties of physical therapy in physical therapy school. So I had learned about pelvic health rehabilitation and sort of the different specialty areas. But it was at my first job, my boss at the time was doing pelvic health. And so I was able to sort of, under her mentorship, learn a little bit more about that. And it piqued my interest further. So I went on for more continuing education to learn about pelvic health and how we could go help treat these types of patient populations like cancer, pelvic pain, bowel bladder dysfunction. And then while I was working with pelvic health patients, I started to see more patients who had experienced cancer. And while that's not in a lot of the foundational pelvic health training, it's a very common side effect. So that made me go, well, I need to learn a little bit more about this, because there's, certain treatments and surgeries that affect all of these muscles and all of these functions. So I went on further to learn a little bit more about pelvic oncology and physical therapy for pelvic cancers.
Do you remember maybe one of your very first cancer patients that got you more interested in learning more about oncology, as opposed to just learning about the mechanics and the physical therapy, but also to delve into more the other issues that cancer patients might face?
Yeah, one of the first, or ones that maybe really stand out the most, are those who experience pelvic pain, especially after surgery and radiation. Those tissues can become very compromised with some of the treatments that are involved. So one client in particular, she had cancer years ago and treatment years ago, and had these issues for a very long time. And I think sometimes there's maybe a stigma about talking about it or bringing it up and discussing these issues. But usually people hear about pelvic health therapy from friends who have done it, or even now on sometimes social media, there's a little bit more presence of there's help out there for this. And she had come to me because she's having actually bowel and bladder issues. And in turn, finding out that a lot of her tissues internally had been, kind of fibrotic, thickened, and just didn't have that elasticity. So we were having all this dysfunction from that. So being able to work with her and kind of, take in all these extra pieces of the puzzle in regards to her cancer treatment was just helpful at looking at the whole picture and not just, what I had learned from the fundamentals of pelvic health training.
Yes. I was just at our national meeting for radiation oncology, and a paper was presented. Even today, the number of women who don't get asked about their symptoms, unfortunately, many cancer doctors focus on the cancer, and the number one thing you do in follow-up is the cancer gone or not? And unfortunately, don't pay as much attention to, okay, you're cancer-free, but what are the lingering long-term side effects of the treatment that you've had? And especially, as you already mentioned, surgery, which changes the anatomy and results in some scarring, and radiation, which results in scarring and fibrosis, more thickening and firmness of the tissue. And that can progress years after the treatment's done and the cancer's gone.
I think sometimes too, it can be overwhelming when you're going through your cancer journey to add one more type of appointment. So I will say, I generally tend to see individuals later on after, they've dealt with this for a few years, but it'd be so helpful if those, that was presented during, their initial treatment of hey, we can kind of address this sooner rather than later, and the outcomes potentially could be better.
Yes, yes. So let's talk a little bit about, let's start with the pelvis, and maybe give us a little anatomy lesson. Why does such a thing as a pelvic therapist exist? What is unique about the pelvis that requires techniques different than working on the knee or the hip or the shoulder?
Sure. I brought a pelvis with me.
Okay.
So we can look. I'm a visual learner, so I think it's sometimes helpful to see what we're talking about. So this is your pelvis. In the front, we have our pubic bone. In the back, we have our sacrum and our tailbone. So that's the back of your pelvis and the front of your pelvis. Now, a lot of times people don't realize that we have a bunch of muscles inside of our pelvis. So if I tip it down, you can see all that red stuff in there. Those are muscles. And these muscles do a few different functions. One, they help with support. They keep all of our organs up and inside so we feel supported. They can help support our bladder and our intestines, and they also help with supporting our pelvic bones. Now, we have small little joints back here that aren't movable like our elbow joint is, but there's a little bit of movement there, and it helps kind of support that. These muscles also act as sphincters, so they help kind of close our openings. So in the female pelvis, we have our urethra, our vagina, and our rectum. And there's sphincter muscles around that. So when they contract, they can stop us from having urinary leakage or fecal leakage. And when they relax and open, they allow things to pass through.
And many of those muscles are under our conscious control.
Yes.
So just like we have a biceps that helps us to, flex our arm, we have these muscles that we can flex that can help keep urine in the bladder, keep stool in the rectum, and obviously a very complex set of neurologic and muscular activity that happens when we go to empty our bladder or empty our rectum.
Yes. Yeah. We need these muscles to be relaxed when we have bowel movements, or in order for our bladder to release urine, these muscles need to be relaxed. Sometimes, I think a lot of times with pelvic floor, we think of we need to strengthen these muscles, but sometimes we need to work on relaxing these muscles so we can have those types of body functions. So while they're under our conscious control, sometimes it's hard for people to figure out where those muscles are and how they work. Because with your bicep, you can see, okay, I'm contracting, I'm relaxing. With your pelvic floor, you're kind of like, where is that at?
And even getting our mind to sort of recognize contracting is much different than the muscles of the extremities.
Correct. So when we assess these muscles, it's very different than, assessing your shoulder, assessing your hip. To assess these muscles, we typically do an internal examination. Now, on females, it's typically through the vagina. We have a gloved finger and we're feeling the different muscles. And for men, it's typically through the rectum to feel those muscles because we want to see how they're functioning. So are you able to contract these muscles? Are you able to relax these muscles? And in terms of pelvic pain, if I press on any one of these muscles, can that reproduce some of your pelvic pain?
And so when you're doing an internal exam, and again, as you said, in a woman, you could do the internal exam with a finger in the vagina or a finger in the rectum.
Correct.
Obviously, with men, it's a finger in the rectum, but you actually can feel some of these muscles with your finger and ask the patient to contract or bear down and feel if there's contraction, ask them to relax and see if they're able to do that.
Absolutely. And that just gives us a good idea of the function of how these muscles are working.
So in someone who doesn't have cancer, would you say that maybe a typical patient that a pelvic therapist would see, and I'll just show my ignorance by I'm sure you can tell us more on different types of patients, but as women get older, especially if they've had children, their musculature laxes and having some loss of control of urination can be a real problem.
Yeah, absolutely.
And that's kind of the classic situation, non-cancerous, that I think of sending to a pelvic floor therapist is a woman who has some loss of control of urine.
Yes.
Is that a common
complaint
common that you would see?
That's a very common complaint that we see because, yes, especially after childbirth or going through menopause, that affects the tissue quality and the ability of those muscles to contract and relax. So we see a lot of that. We also, though, do see a lot of clients kind of on the other end of the spectrum where they're hypertonic or those muscles are overactive, and that can be a source of a lot of pelvic pain. So there's kind of maybe two different buckets you could think of, the ones whose muscles really have a difficult time engaging and some whose muscles are turned on all the time.
And what would be a classic situation of that? Would that be like an athlete, like a long distance runner, or would that what other conditions lead to that?
Yeah, a lot of chronic pain in other areas can lead to kind of our tendency to be a clencher and be tense. I ask all of my patients, I'm like, do you consider yourself a clencher? Do you find that you just hold a lot of tension in your shoulders? Sometimes you're clenching your jaw. Well, a lot of times, whether or not we realize it, our pelvic floor, we can be clenching those muscles too. And that can just lead to this state of being constantly turned on. So we have to work on turning those muscles off. We do see that a lot with gymnasts or dancers because of sometimes the postures they have to assume and some of the activities they perform, they're always kind of in this sort of contracted state. So there's a couple different reasons we would see patients.
And any other non-cancerous reasons that people would be referred to a pelvic therapist?
We see bowel and bladder dysfunction is a big one. Pelvic pain is a big one. A lot of pelvic inflammatory issues like endometriosis, PCOS, so chronic pelvic pain. But then also a lot of times we can have clients who have back pain, hip pain, or other areas that wouldn't immediately think pelvic floor, but these muscles can be a driver for some of that pain. So the lingering hip pain that, you've done all the hip exercises and stretches in the world, but we find it is actually your pelvic floor that's contributing to this. So sometimes our more orthopedic injuries can have a pelvic floor component to that as well.
Before we go on to oncology, maybe describe what a treatment regimen would consist of for, let's say, a 55-year-old woman who's had 4 children by vaginal delivery and is been referred because of stress urinary incontinence or leakage? What would that assessment, and then what would the therapy consist of?
Sure. So the first thing we do with every patient is listen. I need to know about those childbirths. How were they? Did you have any tearing that occurred during that? How did that heal? How has your life and activity level been since then? And just get a really good background so we can make sure we have all the different pieces of the puzzle that could fit into why they're having these issues. What sort of fluid intake are you consuming? Is it mostly water? Are you having caffeinated beverages? Could that be contributing to some of the bladder issues? So learning a little bit more about lifestyle factors. And then I, kind of like I did earlier, educate them on the pelvis and the pelvic floor and what that is. And then so we would do the examination. And with stress incontinence, we typically, again, think it's usually due to weak muscles. But again, sometimes it can be due to tight muscles. Those muscles are holding tension. We cough, laugh, sneeze, and suddenly they go, oh, nope, can't hold it anymore. So we have leakage that way. So that's why it's important to assess. It's important to see what's going on with these muscles. So I would do the evaluation and say, okay, maybe it's a case of these muscles are just not strong. They're not firing. We also then need to look at what are your core muscles like and what is your breathing diaphragm or respiratory diaphragm doing? Because our pelvic floor is the bottom, our core muscles wrap around, and our diaphragm is on top. And that acts as sort of a canister in your abdominal area. And those muscles work together.
And the diaphragm, the breathing muscle that's at the bottom of the lungs, separates the chest. And so as we breathe, those flatten out, helps the lungs fill up.
Correct.
But as they flatten out, they put some pressure on the abdominal cavity.
Correct. Yeah. So we want to see how all those muscles are working together. Because if we're going to prescribe strengthening, don't just want you clenching. We want that to be a coordinated effort between pelvic floor, breathing, and the core muscles. So then typically we look at, okay, what does your strength look like? Maybe we're really low in strength. So that's where we would just start with a foundation of getting those muscles to work together as a team. And as that becomes more efficient, then maybe now we need to add in a little bit of hip strengthening and getting into functional positions. Like I leak when I stand up from a chair. So do we need to work on some glute activation with pelvic floor? So we're just working on getting these muscles basically to work as a team again, because sometimes they just stop doing that, and that's where you get issues.
Do you think that there's a relationship between overall conditioning and pelvic muscle conditioning? Or do you see some people that are just totally fit and strong, but have lax pelvic muscles because of childbirth or menopause?
Sure. Absolutely. Because I think that, again, we know how to strengthen a lot of our other muscles, but maybe we don't know how to strengthen the pelvic floor.
Yeah, I don't think there's a machine in my gym.
Yeah, there's not.
I got the lat pull downs, I got the biceps, I got the triceps, I got pretty much everything, but I've never seen a pelvic floor machine in the gym.
Yeah. Okay. It's probably one, if there was one, people would be doing it incorrectly anyway.
Okay.
Yeah.
And before we go on to cancer,
yes.
What about men that are referred?
Yeah.
Obviously, for folks who don't know, it's not as common to have stress urinary incontinence in men, but it certainly can happen. And this, we'll talk about prostate cancer surgery and radiation, which is clearly can contribute to it.
Yeah.
But besides the cancer diagnosis, what are primarily the men that get referred to you for pelvic therapy?
Typically, those fall more into the pelvic pain spectrum. I find that to be more common, and that also can lend itself to constipation as well. So difficulty with bowel movements. So pelvic pain, if those muscles are tight, that can also cause obstructions for having easy bowel movement. So those are really the most common, but we do see men for incontinence as well. So again, kind of assessing those muscles and seeing what's going on rectally and assessing pelvic floor that way.
Okay. Well, let's get into oncology. So this is an important part of rehab, and maybe we'll do like 3 different patient scenarios.
Sure.
One will be a woman who has cancer within the pelvis, and that could either be the uterus, the cervix, the anus, the vagina, or the rectum, where there's surgery and radiation to the pelvis. So we'll do that first, and then we'll talk about a breast cancer patient who didn't have treatment to the pelvis, but has had medications that might affect it. And then the third situation, we'll talk about men who have had treatment for prostate cancer.
Perfect.
So let's talk about the woman who might be a young woman who's had, let's say, cervix cancer, where she had a combination of chemotherapy, surgery, and radiation to the pelvis, and good prognosis, and is cancer-free, and came through the treatment and was told at the 3 months follow-up, you're cancer-free, go on and live your life. And then issues start happening.
Yeah.
And those issues that if you ask patients about, they can be issues that affect sexual function. So dyspareunia, the medical term for painful intercourse. It can be urinary function. It can be bowel function, or other issues related to the pelvis, even perhaps depending if lymph nodes were involved, some lymphedema perhaps. So this may not come to the attention of the medical team if they haven't been asking proactively questions till maybe a couple of years have gone by. When the scar tissue from the radiation, the scarring from the surgery starts really to become more prominent. And then the patient either gets asked appropriately some questions, or finally is having enough symptoms that says, you know what, this is really an issue for me.
Yeah, a scenario I see often. And it's true. A lot of the treatments that help kill the cancer cells have effects on our musculoskeletal system. So that typical type of patient, we generally see the change of the muscle and the tissues inside of the pelvis. From radiation treatment, they can become, over time, like thick and fibrotic, and we can see shortening of the vagina, as well as like kind of collapsing of the walls in, where the tissue is not as pliable and as flexible. And that can especially lead to pelvic pain with intercourse, pain with even just routine examinations with a gynecologist. So first, like I mentioned, we're assessing those muscles to see sort of, what does it look like now? And a treatment program for that is one, kind of working on some relaxation techniques to let the muscles themselves relax, but then let's also address like the tissue quality. So we can use tools like dilators, which are kind of silicone or plastic cylindrical devices to insert into the vagina to help kind of stretch those tissues a little bit.
Do you have some of those?
I sure do. Yeah. I sure do. So
yeah.
I brought
the assessment before you do the treatment is that you assess that the muscles just are thicker, stiffer, and there's just not the flexibility.
Correct.
The ability to expand.
Yep. Correct. And so these can be helpful. So this is just a pack of them. And these are nice because they're silicones. They've got a little bit of give to them. Some of them can be a little bit more firm and rigid, like a harder plastic.
And they're obviously different sizes that are graduated. So that you could start with a smaller size, help sort of, as the name implies, dilate or make the opening bigger.
Correct. And so the evaluation is helpful because from that assessment, I can be like, okay, you know what, we need to start with this one, or if we can maybe start a little bit higher up. It allows them to have a little bit more customized treatment plan in terms of maybe what size. Where do we start with this? So typically with the dilators, what we can do with that is practice inserting them. So this is something that can be done in the office to help kind of guide the client or patient on doing that. And then they're used at home
and you
regularly.
Would use lubricant.
Correct. Yep. We'd apply lubricant on the outside as well as the opening of the vagina. And then slowly inserting them. And you know what? Sometimes maybe they can only get this much in before there's pain. And I tell patients that's when we pause and we stop and we hold it there. And the goal is to allow for this kind of circumferential stretch of those tissues, kind of a stretch in every direction. So eventually we can get to a bigger space accommodation to get back to intimacy or to, examinations from the gynecologist.
And the sooner we start with this process, the better, because
the sooner the better.
Right after radiation, there's inflammation, but there's not much scarring. And if we can start this process before the scarring starts,
correct,
then you're much more likely to start with one of the larger ones, and the patient may still be a little bit too tender to actually engage in sexual intercourse, but not too tender to do some gentle dilation.
And it's helpful because it's self-guided, so they can really listen to their bodies to be like, okay, maybe I can only handle this much today, and then progress onward. Whereas, sexual activity is, a partnership. So it's a little bit less independent and guided by how you're feeling sometimes. So yes, it's helpful to use these tools to affect those tissues as early as possible after, some healing has taken place after radiation. So.
And you made a good point that there's at least two different reasons. One is to be able to engage in sexual activity with penetration that's not painful. So to have a healthy and enjoyable sex life. But second, even for, let's say, someone who is not interested in that, but they still need to have pelvic exam. We still need to have the doctor look up to the top of the vagina. And if someone is not sexually active and is not using these, the whole vagina can scar down. And every time you do an exam, you're sort of prying it open, causing some bleeding and further scarring.
It'd be very painful.
So even for those women who don't think that they want that they're ever going to engage in sexual activity, it's important for the purpose of medical examination.
Absolutely. Because if there's pain associated with that consistently, maybe there'll be less compliance to get examined, and we don't want that to be in the future either. We want to make sure that things are continuing to be healthy after treatment. So it's important to be able to have that ability to do so.
And I would imagine that in the scenario we started with, a woman who had cancer in the pelvis that got chemotherapy and surgery and radiation, that you're probably not just limited to a vaginal side effect. You're probably going to be experiencing some urinary and some defecation type of side effects.
Absolutely. So with that tightness or rigidity of those muscles, we have that decreased ability to also contract and relax. So those sphincter functions of allowing, the closing of the rectum or the urethra and the opening, that can become compromised. So we can start to have these issues of either stress incontinence, fecal incontinence, where you just can't hold it in, and then we lose control. So part of that comes into retraining those muscles as well. With some of the treatments, we can have nerve damage, sensory issues, or just loss of awareness of how to use and coordinate those muscles.
Right. So you mentioned something we haven't talked about yet, and that is chemotherapy can cause neuropathy. And many patients who've gone through chemotherapy, and let's say it's a woman with breast cancer goes through chemotherapy, often hands and feet are numbness and tingling, but you can also have some neuropathy that affects internal organs or the pelvis.
Absolutely. So we have other strategies to kind of help with that awareness. We can utilize a device called biofeedback, which would be like external or internal probes that allow, and they are hooked to a device that has like a little kind of gauge that goes up and down. So we can, teach them how to contract those muscles. And ideally when they contract, that little lever goes up or the little dial goes up. So they can see like, okay, that is a contraction, or we can use that to also help relax. If we're starting from a heightened position, let's try and get that to come down. So helping with some of that awareness, maybe even if our sensation has been affected.
Sometimes you tell us, well, just do a Kegel exercise.
Yeah.
And you're like, well,
like, what does that mean?
Am I doing? So to be able to have that feedback where the patient can visually see how their contraction of pelvic muscles actually result in changes in pressure or flexion. What would be the device actually be measuring?
It's measuring kind of the electrical activity of the muscle. Okay. So basically it's a good way of, the contraction of the muscle. It's not a good correlation to strength per se, but whether or not we can just engage and relax. So,
okay.
Yeah.
And then let's talk a little bit more about treatment.
Yes.
So we've got the woman who has dyspareunia, pain on intercourse, but also some urinary and bowel difficulty.
Yep.
So we talked about using the dilators for the vagina. What other treatment regimen would you use for overall pelvic health for the woman that we just mentioned?
Yep. So we talked briefly too about the breathing component. And I think that's maybe a unique subset of our clinic is we assess breathing with every single patient because breathing is the foundation of life, right? So we look at how they're breathing and how that's affecting their core muscles, their pelvic floor muscles, and teach them how to breathe properly using that diaphragm. Sometimes also with this sort of course of treatment, we're looking at other muscles around the area too. Have we lost like hip mobility? Have we lost mobility through the low back? Do we need to address some of the maybe scar tissue restrictions externally? So like through the abdominal area, and see kind of how all those tissues are functioning and working as well. So treatment-wise, we have our dilator option, we have our biofeedback. We also then are looking at everything around the pelvis as well, our low back, our hip mobility, and giving them an individualized program of like, here's some things you need to work on at home. Maybe it's the dilation, maybe it's the strengthening. And then here's kind of what we're going to be doing in the clinic is kind of the teaching and retraining portion or some hands-on techniques of like internal sort of manual stretching of the tissues or working through some of the abdominal scar tissue. So it's, very individualized and can shift based on, a patient's goals and where they're at, in their treatment progress.
And typically, how long would a person be working with you? How many sessions a week? How many weeks?
Sure.
I know it's very individualized, but maybe give us an average of the amount of time you'd work with a patient.
Yeah, and that's a question all of my clients ask me, and it's always an "it depends" answer, which is very unsatisfactory in many ways, but it does depend on so many things. Typically, I tell my patients I want to see progress within 4 to 6 weeks. You may not be like fully better at that point, but I want to see that we're moving in the right direction. For my clients who had this type of surgery and treatment 10 years ago, we're probably looking at a longer course of treatment because we've had the tissue.
Lots of scarring that's not been stretched for a long time.
Exactly. So we may be looking at months to sometimes years, but it may not be that you need to be coming to see me, twice a week, every week for the next 5 years. It's like, okay, maybe we need check-ins and here's some more homework that you can do on your own. And then we'll circle back and see how we can progress that. For those who I get to see a little bit sooner on, generally they have a shorter timeline that they need physical therapy for, but then also here's some exercises that might be beneficial for the rest of your life, kind of sprinkling into your exercise program already that you do.
Is there any evidence of value of seeing a pelvic therapist before you start the treatment?
Absolutely.
Most of the time the focus is, we got to get started. The patient wants to get started. The doctors want to get started. It's all focused on killing the cancer cells and the idea of putting in 3 more appointments before we get started. But I'm just curious whether which patients do you think would be ones that might benefit from being seen ahead of time?
All of them. Quite honestly, all of them. Because even if, it's something that we can just look at, get a baseline measurement of like, where are you at now? What does your function look like now? Then afterward, we can see how much has that changed and maybe where do we need to direct our efforts a little bit more? Or just teaching the fundamentals of that breathing or some hip stretches that can help while we're not directly treating pelvic floor during radiation because it's healing, but maybe we can work on some hip mobility because some of our hip muscles are part of our pelvic floor. So getting these types of things involved earlier on before treatment are, super valuable afterward.
And, another benefit, Rachel, would be if a patient saw you, they already get then in tune to using the words. And to talking about the function and much more likely then to report when they're having dysfunction.
Absolutely.
Because unfortunately, because of the sensitive nature and oftentimes, I mean, this is not an excuse. I'm just saying that the way it is. You've got a male doctor who's really focused on killing the cancer, and the idea of then saying, "And how is your sex life coming along?" In the middle of a treatment evaluation, it just doesn't happen. I mean, the data shows it doesn't happen. That women aren't asked about sexual dysfunction. So getting a pelvic referral up front gets sort of the woman gives them permission. Not that they need permission. But it would more normalize the conversation for ongoing follow-up.
Absolutely. And that's something, I kind of established at their first visit, like, you can tell me anything you feel comfortable telling me. There's nothing off limits in these 4 walls, because we have a private treatment room for that purpose. So no one's going to overhear any sort of conversations we have, and we can talk about it all, because that's all I do all day. So, yeah.
Let's transition to a man who's had his prostate removed or radiation to the prostate for prostate cancer, or both, had the prostate removed and then still needed radiation. So now we've got the male pelvis who is now dealing with issues of urinary incontinence and erectile dysfunction.
Urinary incontinence is absolutely common with prostate surgeries. Research has shown that, even we talked about prehab before, so a visit before surgery, there are very big benefits of having a consultation, of learning how to use those muscles before prostate surgery or treatment for improved outcomes after. So again, kind of making sure we're taking an in-depth analysis of, all the things that went on during their treatment, their surgery. What sort of things do they notice their incontinence with? Is it coughing, laughing, sneezing, certain movements in particular? And that way it can help kind of guide, what sort of exercises or how we incorporate function into that. So again, we would assess that rectally with using a gloved finger in the rectum to have them try and squeeze those muscles. So sometimes the cues for engaging those muscles can be a little bit different. So for a male Kegel, kind of thinking about kind of shortening the penis or pulling the testicles up and in. For, the female patient, sometimes I think of, if you in a sitting position, if you're sitting on a Kleenex, can you try and pull that up and in? So it's different cues to help engage those muscles, because sometimes it's hard to find. So seeing if they have that ability to contract those muscles and relax, and then kind of like before, working on different types of other muscle groups to help coordinate with some of that strengthening. And when we work on pelvic floor function, that can help with blood flow to the pelvic area. So for issues of erectile dysfunction, that can help improve blood flow. So all of these things are sort of interconnected that way.
Okay. And then let's go to the third patient, and that's a breast cancer patient who had chemotherapy, mastectomy, radiation, and anti-estrogen pills. So we've got someone who's facing many different side effects: the surgical, the radiation, the chemotherapy, but then also, not only the natural loss of the estrogen that might have happened, but then being on anti-estrogens. So I know that in addition to pelvic therapy that you're specialized in, you have a specialty in breast oncology. So if a patient like that comes to see you, what would be the assessment you would do for the upper body? And then also, in light of maybe having been put into premature menopause, what might be the pelvic issues that woman would experience, even though she didn't have any surgery or radiation on the pelvis?
Sure. So starting with kind of the upper quadrant area, the upper body, we would want to especially look at first posture, because with those surgeries, we tend to get this kind of forward collapse posture, either due to scar tissue or due to just changes through the treatment, having to be in this forward flex position. So we want to look at posture and see, what does our movement look like through the chest wall? That can affect our shoulder function and arm movement. So we want to see, how is the shoulder working? we want to look and assess any of like the skin changes that can happen from surgery, from radiation. What does that tissue look like and how is it moving? So addressing scar tissue limitations through like the mastectomy site is very important to just get that full mobility. And then I know I circle back again to this, but breathing is so important because we need to be able to expand like through this area to get those deep quality breaths. So we want to look at all the different types of function. And most commonly I see definite limitations in like overhead reaching with mastectomy patients. And sometimes that can be affected due to like the lymphatic system. So.
Right. And so you haven't mentioned it yet, but you would also be assessing for lymphedema.
Correct.
Or swelling of the arm.
Correct. So we want to see, do we have any congestion issues in the lymph system? Now, I'm not lymphedema certified, but I am able to assess and see, like, do we need to send you to someone who is lymphedema certified so we can make sure this doesn't become a cascading event where we get.
And we've had some of our lymphedema therapists give talks here. So, but obviously, even though you don't have that credentialing, recognizing the lymphedema is certainly within your
absolutely
your training.
Yeah.
So that's what you would do above, and then when we talk about the pelvis for a woman, it's really, I think, probably the issue of in many cases premature menopause or a hyper accentuated menopause due to the anti-estrogens, and maybe also an effect of chemotherapy in terms of potential neuropathy.
Yeah. Estrogen is a main hormone that really helps our overall like vaginal tissue health. So when we have, a hormone-based cancer where we're really suppressing this estrogen, that can affect the tissues of our vagina, our vulva, our pelvic floor. So we see these de-estronized tissues that get maybe thin and more fragile and less lubricated. So we need to look at that and see, okay, how could this be affecting maybe sexual function or again, bowel and bladder issues? And do we need to look at any sort of lubrication for sexual activity, or even just moisturizers to help with that loss of self-lubrication and see how that affects our tissues.
Yeah, I've had patients, women who've been through breast cancer surgery, who participated in cycling classes, going that, just the even not only talking about the extra lubrication that happens with arousal, but just the normal lubrication and the difficulty and discomfort that can happen with cycling.
Yeah, we can, talk to them about different moisturizers that are out there that are, lubricants we use a little bit more for intimacy or even for the diluted work, but then moisturizers that they can be using on a regular basis to just help with the like feelings of dryness throughout the day, since we lose that ability to self-lubricate as well.
Okay. You know what? I think we're going to open it up to questions now. Sure. So we have a live studio audience, and they're very lively. And we also have folks that are watching us live streaming, and they can submit their questions through the chat box. And we'll start off with some questions here in the audience.
My question is, person with bilateral mastectomy, and do you see tendonitis of the elbow or tennis elbow?
Yeah. So I think the important part is like zooming out and looking at the bigger picture. So if we have limited mobility here, sometimes our other joints have to make up for it. So we can start to develop issues in the elbow, maybe in the wrist and the hand, from those areas having to like compensate. So absolutely that can be common. So we have to sort of look at all the different things that could be correlated.
Okay. So with lymphedema, would you recommend dry needling on the opposite arm?
So with lymphedema, I would always kind of defer to the oncologist to make sure that is okay. But with the training, they show that actually there's a lot of positive benefits. We want to be, aware of any sort of like needle sticks. And if there is an active, large lymphedema going on, I would maybe not do at that point. But if we have lymphatic congestion, sometimes needling through maybe the pecs or into the upper shoulder area can help relieve some of that muscle tension. So maybe we can get the lymphatics to move a little bit better. So it can definitely be helpful with that. But I think there's certain things that we need to pay attention to before we jump into dry needling. But yeah.
Hello and good evening. I'm really fascinated on your presentation in relation to your props that you brought.
Yes, thank you.
And we talked about the bones and muscles, but what also goes through that area or around that area very closely are veins and arteries, and also the nerves that go through there too. Yeah. So from like a cancer diagnosis where someone did have treatment, do you have any people coming in to say, I know it's a vein, I know it's a nerve?
So it's sort of like a sciatic nerve irritation or varicose veins or...
So do you do anything with the nerves? Those.
Yeah, absolutely. So nerve entrapment can happen due to some of the either the scarring or the tissue adhesions or the tight muscles. We can get those to kind of push down and put pressure on the nerves, which can cause, I think, especially sciatic pain is a very common. We get pain sort of down the leg, and that nerve runs through our pelvis. So sometimes these muscles or the tissue or adhesions can be a source of compression for those nerves. So there's a few different special tests we can do to see like how the nerves are moving, but then also just assessing the tissues around to see where is that getting irritated at and what can we work on to help kind of relieve some of that compression.
And you do see some type of numbness in the legs.
Yes.
One of the symptoms that you can back up on.
Yes.
Numbness in the legs.
Yep. Numbness, tingling, sometimes that burning, shooting pain down into the legs are all very common, like nerve complaints. Yep. Yeah.
Thank you. Other questions? We have a question over here.
How long after surgery is it common to see these patients in your clinic? And if it's farther out, then is there anything that you can give to someone maybe that's going into surgery, like some movements, some breathing techniques to try and help kind of calm their nervous system down immediately post-surgery? Post-surgery.
Yeah, absolutely. So with, pelvic radiation, when we talk about dilators or any internal work, we usually want to wait a few weeks after radiation has been completed just to make sure the tissues have, healed, that we don't have any open wounds, and allow some of that healing to occur. But we talked about earlier with like kind of the pre-habilitation or the work before, there's a lot that we can give people to work on. So calming the nervous system is a big thing, because when we talk about those muscles being tight, that deep breathing, gentle mobility exercises to help maintain range of motion, maintain function, or at least allow for the side effects to take less of a physical toll if we can try and work on some of this stuff before.
Yeah. Good reminder about prehabilitation. Yes. And you're talking about radiation, and as just a reminder, when you're getting the radiation, you're often the inflammation. So you see the redness of the skin, you see a little bit of swelling of the tissue, and that's an inflammation. And then the scarring is a late effect. And so you kind of want that sweet spot of having the inflammation having settled down, but start the therapy before the scarring actually begins.
Yeah. Yep. That sweet spot's usually a few weeks after you wrap up the radiation too. So,
Okay.
Yeah.
Good question. Yes.
Yeah, I was a question about breathing techniques, and that everybody in this room, you're born breathing.
Yeah.
You have an innate breathing technique. Is there something about that technique that as you age, it just doesn't stimulate those pelvic floor muscles as it should be doing? Or
Yeah, I actually have a really kind of interesting story about this. So I have a 14-month-old boy at home, and I was watching him breathe the other day. He was like going kind of crazy on the couch, climbing all over the place, and he plops down, and I watch him breathe, and he is just doing this beautiful diaphragmatic breathing. So his belly is rising and falling with each breath. So you are right. We are born knowing how to breathe correctly. Over time, for whatever reason, sometimes with stress, sometimes with injuries or dysfunction, we start to compensate by using these upper chest muscles to breathe, and that actually limits the use of the diaphragm. So when we teach these breathing techniques, we're thinking about relearning how to use this diaphragm and not breathing with all of these muscles up here. So it is really common that I lay people down like, okay, take a big breath for me, and I see this like big chest puff up and their belly sink in, and then I tell them exhale and their chest falls and their belly pushes out. And that's the opposite of what we really want. We want
when we inhale,
Yes.
our belly goes out.
Yes, our belly, our ribs should expand, and we should feel like almost we're breathing into our back. That gets the whole diaphragm. So it's sort of like there's a balloon analogy too. If there's a balloon inside our abdominal area, that balloon should expand in every direction because we're filling with air. Then when we exhale, that balloon kind of comes back together into its normal shape. So we want that kind of 360-degree breathing. So we use our diaphragm and not all these accessory or upper muscles here. Yeah.
So just a person in normal health could benefit from
Yes.
strengthening their pelvic floor.
Yeah, absolutely. Making that connection again, and again, learning how to breathe. You think it's intuitive, but we find out a lot of us are actually kind of not doing it correctly all the time. Yeah.
Other questions? Yes,
George.
George.
So we're talking about physical therapy, but
Yeah.
the mind and body work together.
Mm-hmm.
And for the physical therapy to work better,
Yeah.
the mental aspect has to be a part of this. Is that
Yes.
becoming increasingly important in physical therapy and in your training and in your
Yes.
practice?
Yes. At our clinic, Breathe, we have a good relationship with a lot of mental health therapists in the area, especially ones who have knowledge of like pelvic pain or sexual dysfunction, because while, I am willing and able to talk about all these things, I am not a mental health therapist. So sometimes we need, to have these additional providers who can provide those strategies. There is a huge mind-body connection, I think, especially when it comes to the pelvis. So we very commonly will refer out to other providers, and we work kind of together to help make this cohesive treatment plan. Mm-hmm.
Maybe to follow up on that, and thank you for. I forgot at the very onset of our program to mention that you're with Breathe Physical Therapy. That's the name of the physical therapy practice that you're with.
Yep.
When you're talking about sexual function, let's say you have a female client.
Mm-hmm.
Obviously, there's the physical aspect of what's going on, especially if you've had surgery and radiation. But sexual function, as has been mentioned, is very much a cognitive and an emotional and psychological, and there's a lot going on. And I suspect, and maybe you can tell us the difference between a pelvic physical therapist and a sex therapist. And at what point does a pelvic physical therapist who's treating a woman invite let's say in this situation, a male partner to be part of the conversation?
Yeah, that's a great question. So usually I like to bring up maybe a sex therapist or a mental health therapist early on, as just maybe even dropping that in there. Like, have you thought about speaking to this type of provider? And then I also then talk to, the client, if that is something that they want their partner to be involved, and maybe their partner wants to be involved, they can come whenever they want, as soon as they want, to kind of help even be a support person or see, some techniques I'm using. I've even taught some like pelvic stretching, like manually to partners before, be like, okay, this amount of pressure in this area, and then kind of talking through different techniques that way. Because I think that allows for a little bit of regaining of some intimacy. Even if we're kind of addressing medical components, it's a way for them to sort of be involved in the process together, which can be really, really helpful.
Thank you. Other questions? we have any from our, here we go.
I have a question about, say, if you have an excessive cough or do a lot of excessive sneezing.
Yeah.
Does that really affect, the base?
Absolutely. Yeah.
And is there things that perhaps we ought to think about, if we, get into those situations?
Yeah, absolutely. So with a cough, laugh, or sneeze, that puts a lot of pressure in our abdominal area. There's a big force and it moves straight down towards your pelvic floor. So if those muscles can't support, that's where we can get a lot of leakage from, because we talked earlier about that kind of canister inside. If one of those areas of the canister is not working, we can have that dysfunction of leakage. So repetitive coughing or sneezing, especially during allergy season or flu season, is a big thing that we start to notice sometimes the leakage with. So one of the strategies, which is a pretty simple strategy, is trying to engage those muscles perhaps before you feel a sneeze coming on, or trying to engage those muscles as you cough, just to help with that support. And that's not an easy task sometimes. So that's why it comes down, we have to work on sort of retraining how to get these muscles to work together. But if we can work on that pelvic floor strength and support, then our bladder is better supported. So when we have a cough, laugh, sneeze, we don't have that leakage issue happen. So sometimes that comes into that strength training component. Yep, and getting that coordination down. Yeah, absolutely.
Well, Rachel, thank you so much. Rachel Gage, physical therapist at Breathe Physical Therapy, and has training in pelvic floor medicine, pelvic oncology, breast oncology, and dry needling. Thank you for being with us.
Thank you so much for having me. I appreciate it.
And thanks everybody for attending this evening. If you know someone who would benefit by watching or listening to this program, tomorrow it will be available on demand at the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website. Please join us again next week. Thanks.